Hi, I'm Sneha Sharma. I'm a graduated internal medicine resident at University of Cincinnati Medical Center and a rising QI chief at the VA. Today we're going to be discussing post-heart transplant management and rejection medications with the lovely Dr. Cook. Dr. Cook, if you'd like to
Well, hello there, everybody. So this is another one of our CVICU-B primer series. And whenever you're on the CVICU-B service, you're going to be seeing transplant patients from time to time, both those that we're considering for transplant and those that are readmitted. And so we have prepared this presentation for you today so that it won't be the first time you are exposed to these ideas and concepts. And as a special treat today, we both have worn our Wonder Women t-shirts. Can we see? Yes, because we are Wonder Women of internal medicine. And actually, you may have seen the photograph on the website of the ladies, the lovely ladies on call one night with their Wonder Woman t-shirts. And I was so honored to have Dr. Sharma provide me with my own Wonder Woman t-shirt that I love to wear on call as well.
You truly are a Wonder Woman, Dr. Cook. It was in your honor.
Oh, awesome. Okay, so let's go.
Yeah, let's start. So the first slide we have is basically the patient exclusion criteria, which patients do not meet criteria for heart transplant or possibly LVAD that's meant to be a transition to heart transplant. So anyone with an active infection, malignancy that has poor prognosis. So you'll often see when we get a patient with end-stage heart failure that has malignancy, we get oncology on board to give us a prognostic decision. Anyone with advanced age, basically over 70 years of age, is not considered, unfortunately. Hepatic fibrosis as well. And then poorly controlled type 2 diabetes is also a risk factor because of high risk for post-op infections and immunocompromisation. Increased pulmonary vascular resistance, everyone we consider goes through a right heart cath that's diagnostic. So if their PS systolic is over 40, their pulmonary gradient is over 14, or the pulmonary vascular resistance is over 4 Wood's unit, they meet the exclusion criteria.
And of course, that the PVR we look at so closely, because if we transplant a patient who has elevated PVR at baseline, the right ventricle fails post-transplant. So that's the reason why we're so careful about that. And so you'll see us really scrutinizing those SWAN numbers in the patients that we're considering for transplant. But that kind of brings me to the question, so these are the patients that are too sick for transplant. And so how do we identify those patients who are sick and need to be considered for transplant? Can you share a couple of the things that maybe you've seen before, Sneha, on the wards that led us to trigger a transplant evaluation?
Yeah, someone with extreme left ventricular heart failure with EF of less than 10%, continued VTs, arrhythmias, on inotropes that will not going to sustain them for a long period of time is what I have seen being considered for transplant.
Absolutely. Because the patients that are like that end up being sick enough that they can actually be listed in a transplantable position. And as we are taking care of hundreds of patients in the outpatient setting that have class 3 symptoms, we also have to kind of anticipate which type of symptoms in our patients who have acute decompensated heart failure have risk factors of developing end-stage failure like you've described. And so a couple other things that will trigger us is actually admissions to the hospital. So if you have more than one admission to the hospital in 6 months for heart failure, you should be considered for a transplant or a VAD. If you have hyponatremia, if you have end organ dysfunction. So this list mentions hepatic fibrosis, but if you have hepatic insufficiency, renal insufficiency, or pulmonary hypertension related to your heart failure, you should be considered. And then the patients that have lower blood pressures, and we really can't get them on guideline-directed medical therapy. These are the folks that show up with coreg of like 3.125 and 5 lisinopril, can't tolerate Entresto, and we can't up-titrate the medications because of hypotension. That's another one. And the final one, and there are more, and this will come up on the wards, but I just wanted to give you kind of a smattering of these, is high requirement of diuretic. So if a patient is on the equivalent of 80 milligrams BID of Lasix or more per day, then they should be considered for a transplant as well.
That's actually very insightful, Dr. Cook. Thank you.
Sure.
All right. The next slide we have is mortality. So this is post-transplant mortality. So at 30 days is the highest chance of mortality, and it's most likely due to acute allograft rejection, which accounts for 40%, and infection, which accounts for 13%. At 1 year, the mortality due to infection is 33%, graft failure is 18%, and acute rejection is 12%. And then 5 years, graft vasculopathy is at 30%, malignancy is at 22%, and we'll talk about that more. And then infections at 10%. So as you see, as the time from the transplant goes further progresses, graft vasculopathy kind of accounts for majority of the mortality. And we have medications that we use to address that as well. And then rejection. So specifically talking about rejection, you will see in the CVICU when we have a patient that has just recently received a transplant. He's the first patient, he or she is the first patient we round on in the morning, and there's multiple teams involved. There's cardiac surgery, CVICU team, the B team, and then the CCAT team as well. And the rejection medications is the highest discussion, the most discussion we have about for those patients. So it's because the highest risk is in the first 6 months, and then perioperatively they get thymoglobulin, and then OKT3 as well, which is a monoclonal antibody.
And one thing I'll accentuate about that is the induction therapy is given for patients that we want to spare their kidneys from some of these more kidney toxic medications. And so if we want to hold off and giving them their calcineurin inhibitors for a week or so, we might give them thymoglobulin. Or if they're at a high risk group, like they are pre-sensitized and have preformed antibodies, they may get thymoglobulin. I would say that we induce probably between 10 and 20% of patients that have transplant.
Oh, okay. So not everybody, but those who are at risk for kidney. Okay, got it. And then, like Dr. Cook mentioned, there are 3 classes of immunosuppressants that are used. So the calcineurin inhibitors, which is cyclosporin, tacrolimus, sirolimus. They inhibit the T cell, IL-2, and other cytokine inhibition. That's how they work. The antimetabolites, which is azathioprine and mycophenolate. So azathioprine works on the T and B cell proliferation, and the mycophenolate works on the RNA DNA synthesis inhibits the guanine synthesis. And then prednisone, which is just reduces inflammation globally, reduces neutrophilic excitation out of the vasculature. And then there's proliferation signal inhibitors as well. Specifically, when the patients are getting their immunosuppression, the medications are timed for 9 a.m. and 9 p.m. So you will see that pharmacists work with us very closely to make sure that the drug levels are ordered at 8:30 a.m., which is supposed to be 30 minutes before their scheduled dose of tacrolimus, let's say. So if you're ordering labs for especially tacrolimus levels for the next morning, you have to make sure it's timed 30 minutes before the patient gets their morning dose.
We spend a lot of time working with the nurses and the phlebotomist to make sure that this gets done, but you can just expect that every single patient who's in the hospital is going to get drug levels every single morning. And so when we miss a morning, it messes everything up. So do everything that you can to get the orders in correctly and the drug level ordered correctly every day.
Yeah, exactly. And then signs of rejection. So we have a pretty high threshold for patients who have heart transplants. They could be completely asymptomatic coming for rejection, and we admit them and monitor them. Of course, fever, dyspnea, cough, nausea, vomiting as well, hypotension, new arrhythmias I've seen pretty commonly. And then signs of heart failure, peripheral edema, ascites, weight gain, increasing diuretic needs, and hepatomegaly. So those are definitely some of the things that I've seen that we've admitted patients for in the CVICU.
Absolutely. And so honestly, if a transplant patient calls us and complains of anything between their like chin and their knees, we consider rejection. I mean, that's how low of a threshold that we have a suspicion for rejection in these people. And you might notice that several of these are acute infection, and certainly acute infection, rejection can pose as acute infection, but also acute infection can rev up the immune system and precipitate rejection. And so that's the reason why these fevers and the viral symptoms can sometimes precipitate rejection. And finally, when you're admitting a patient who's had a heart transplant, you should assume that they have a perfectly normal heart, that their heart is absolutely normal. So any heart failure symptoms in a post-transplant patient should be considered rejection until proven otherwise. Now, certainly some patients may have a history of rejection or have known graft dysfunction. Hopefully that's very well documented in the medical record so that you can consider that their underlying graft dysfunction. But your first assumption should be that a post-transplant heart works perfectly.
It's very interesting, Dr. Cook, that you mentioned that infection can itself rev immune system. We actually had a very young patient with a heart transplant history who came in with appendicitis, but then also had acute rejection at the same time going on. So we had to manage, it was a very complicated situation, but yeah, I've seen it.
Yeah, absolutely. And you end up, the other thing that happens for these patients, especially if they have GI illnesses, they can't take their medications or they vomit up their medications. And so sometimes our transplant patients who have acute viral illness get admitted just so that we can supervise their immunosuppression and give them IVs if necessary.
Absolutely. All right. So cardiac allograft rejection. So it's most common in the first 6 months after transplant. It is associated with increased mortality because it leads to the development of allograft vasculopathy. The gold standard of surveillance and diagnosis is endomyocardial biopsy, where we get a sample of the right ventricular wall. Is that right, Dr. Cook? Yeah.
Septum.
Septum, yeah. Okay. And then that sample is sent to the pathology lab, and then also for DSAs. And I'll talk about that. We'll talk about that later. And that basically tells us the grade of rejection through the path exam, and then the DSAs are usually the attendings get a call about. There are some disadvantages of biopsy. There is procedure-related complications. So patients who have to go through a lot of biopsies, the buyer has to basically pass through the tricuspid valve, and eventually they could develop tricuspid regurgitation. Patients, of course, uncomfortable because it's an invasive procedure. And then even there's been known to have some intrapathology interpretation variability. I think it's pretty guideline based now at our facility, but that is just something to be aware of. Anything, Dr. Cook?
I guess the only other thing I would mention is, I don't think this is part of the slide deck, but you might see something about an AlloMap. And an AlloMap is a blood test that we do that looks for DNA that's associated with rejection. And so we're using AlloMap instead of biopsy in patients who are greater than a year post-transplant. And if their AlloMap is elevated, then they'll get brought in for a biopsy. And so you might see in the records mention of AlloMap, and that's what that is. It's a blood test that's an alternative to a biopsy.
And then hyperacute rejection, I fortunately have never seen this in our system, but it's the most feared complication. It's almost immediate, aggressive, and lethal immune attack. Basically, at the time of the transplant, there's like preformed recipient antibodies to the HLA antigens in the donor. And as they're closing the vasculature, there's thrombotic occlusions and hemorrhage of the graft vasculature that can begin within minutes after the graft is placed. And the mechanism of this is basically the antigen recognition activates the complement system, so you get immediate influx of the neutrophils into the area that causes inflammation and then ischemia. So even before transplant, when they're matching to see if the recipient is a candidate for the heart that is available, there's cytotoxic cross-matching to make sure that there is no hyperacute rejection. And I'm forgetting the name of the test, Dr. Cook. I think there's like is there a certain lab number that we look for this pre-transplant?
So what we'll do, and it's so interesting because as a heart transplant doctor, I wear a lot of different hats, and immunology is one of the things that I always pull back from my medical school days as I'm taking care of these transplant patients. And the whole concept of rejection is that the recipient's body is reacting to the graft. And it can react to the graft either by being sensitive to the cells, or through, and that's T cell or cellular based rejection, or to circulating antibodies. And so hyperacute rejection usually is related to circulating antibodies that react to the heart. And so basically what happens is that we make a mistake where the recipient has an antibody to the heart we give the patient. And if that happens, they're going to respond to it aggressively with hyperacute rejection.
Thank you, Dr. Cook. And then the next one, we have acute cellular rejection. So this is the most common form of heart transplant rejection. It usually is most common in the first 3 months, but it can happen anytime. We had a patient 18 years from his transplant that we saw this in. And then it is characterized by T-cell mediated response against the donor allograft with macrophage and lymphocyte infiltration. And the risk factors are younger age recipient, female gender, both donor and recipient, and then higher number of HLA mismatches. That could happen. And we see that actually quite often.
Yeah, and these patients get biopsied a lot. So they're going to get biopsied once a week, and then they'll get biopsied every other week, and then once a month. So in the first year, they get biopsies on a regular schedule, whether they need them or not. So whether they have symptoms of rejection or not, because we know if we treat acute cellular rejection before there's significant graft dysfunction, typically the graft function returns to normal. So we want to catch it as early as possible.
Yeah, absolutely. And then there are 3 grades, and this is more technical, but these are just histopathological findings that we just wanted you guys to be aware of. So there's 3 grades of acute cellular rejection. There is mild, where they see interstitial or perivascular infiltrate, ACR2, which is moderate, which is greater than 2 foci of infiltrate, and ACR3, which is severe, which is diffuse infiltrate throughout the sample, and has edema, hemorrhage, and vasculitis. Interestingly, I was on CVICUB, and my attending actually got the image of the pathology, and they were able to determine what kind of rejection it was too. So it's a very hands-on discussion with the pathologist. For ACR2 or greater, we treat the patients with corticosteroids, and we modify their immunosuppression basically to be more robust. If they are symptomatic as well, there's been literature on it. Yet I have not seen this yet, but we usually add an anti-thymocyte globulin that we could possibly add to the ongoing therapy. And then the big worry with this is there's a higher incidence of coronary allograft vasculopathy with these patients. That's what CVA stands for, and mortality. And then the next one is the antibody-mediated rejection, when recipient antibody is directed against donor HLA antigens on the allograft endothelium. And this basically initiates a complement cascade that causes tissue injury via inflammatory pathways. I'm sorry.
We have simultaneous puppy noise and children noise in my house.
She's found a toy that she wants me to play with.
So back to AMR.
Risk factors. We have so if patients have elevated pre-transplant panel of reactive antibodies, so PRAs are high, or they have positive donor-specific cross mismatch, that's also a possibility. CMV seropositivity and prior LVADs are also risk factors for this.
And so this is our only slide on this one, right?
Yeah.
Okay.
The next one, we go into the pathology.
Show me the next slide real quick.
Yeah.
Okay, go ahead. I didn't want to interrupt yet. I want to let you go ahead.
No. Okay.
Yeah.
So there's 3 grades of severity. Like basically we talked about with acute cellular rejection. There's one where there's histological findings, and then there's only one immunological pathology findings, which is the CD8 positivity or C4D positivity. Where 2 is you have histopositivity and immune findings positive. And then AMR3 is where basically we're seeing interstitial hemorrhage, capillary fragmentation, more significant pathological findings. And the reason why we do this is basically our management changes if they're grade 2 or higher within corticosteroids and modifying the immunosuppression. And then if patients are symptomatic, we can consider IVIG, rituximab, bortezomib, or plasmapheresis. We've actually given bortezomib to a patient, and that's basically like getting a chemo. You have to get chemo consent with help of pharmacy as well.
Mm-hmm. And I imagine if this is the first time that you've been exposed to rejection, this all might feel kind of overwhelming. And so this slide are going to be available as a resource for you. And so you can download them and use them as notes as you're following along with your clinical patients that you might be treating. But as we're kind of summing up this rejection, just to kind of put it back into perspective for you, there are two main types of rejection: cellular mediated and antibody mediated. Cellular rejection is diagnosed by biopsy. Antibody-mediated rejection is diagnosed by biopsy, but also looking for circulating antibodies in the bloodstream, which is the donor-specific antibodies. And so that's kind of the general overview of rejection. So two types of rejection. One is biopsy alone. The other is biopsy plus circulating antibodies.
Yeah, exactly. Thank you so much.
Yeah, of course.
The next one we have is GAT-graft vasculopathy. And it basically, because of the degeneration of the heart post-transplant, patients can have silent ischemia. So they, for the most part, can get yearly screening angiograms. Of course, our limitation becomes their renal function. So we monitor that closely, but that's always a possibility, always should be in the back of your mind. Prophylaxis for them, you'll always see patients on aspirin and statin. Pravastatin is the one that has been studied in literature, but Dr. Cook had previously mentioned that if they're on a higher potency statin, we usually continue that for them. And then I've often seen this too. Patients get interventions and the success rate is 92%. There's restenosis in 20 to 55% of the patient at 15 months. And then they get drug-eluting stents in about 30% of the patient. We usually can treat these patients with tacrolimus or sirolimus or everolimus if they're not able to tolerate the tac.
Yeah, you might have heard of the word sirolimus and everolimus before in cardiology, maybe even on the A service, because this is what we put in stents. So they coat stents with these drugs because they're anti-proliferation agents. So they decrease the proliferation of endothelial cells. So it makes perfect sense that if we have a disease where there is proliferation and narrowing of the coronary arteries, that something like sirolimus or everolimus might be helpful. And the other thing I'd tell you is that if you've never seen graft vasculopathy, but you've looked at angiograms before, the best way I can describe it is if you've ever seen an angiogram of someone who's a type 1 diabetic and they just have very diffuse narrowing of the coronary arteries, that's what allograft vasculopathy looks like. And so it is an endothelial disease with chronic rejection that leads to endothelial proliferation and narrowing of the arteries. And so a lot of times there isn't a discrete lesion to stent, but they do receive PCI if we think that there is an area that is amenable to percutaneous intervention. But many times we're just following these patients and watching them. And the graft vasculopathy often leads to problems with diastolic function. And so patients who have severe graft vasculopathy sometimes will present with HFpEF. Got it.
That's a really good, thank you so much, Dr. Cook. That was a great explanation. And then the next thing that we switch to, which they're of course at risk for as well, is infection. When patients are on prednisone, our goal is to wean them off of prednisone as soon as possible. We'll discuss this slide more, but CMV prophylaxis, you look at the donor and recipient status, and we usually do valside and acyclovir. And then for PCP prophylaxis, they're usually on Septra. Our pharmacists are incredible in CVICU BA team, and they help us manage a lot of these medications as well.
Mm-hmm. So the patients will basically be on all this prophylaxis as long as they're on their prednisone. But remember that if we have to treat a patient for rejection and they're going to get pulsed with steroids again, they have to go back on their prophylaxis after their rejection treatment.
Yeah, absolutely. And then malignancy. So this is, we had discussed that there's an increased risk of malignancy. Which one? So there's a 20-fold increase in the chance of getting a non-melanoma skin cancer and non-Hodgkin lymphoma. And then 5-fold increase in getting melanoma, leukemia, as well as cervical and vulvovaginal cancers. 3-fold increase in testicular and bladder cancer, and 2-fold increase in colon, lung cancer, esophageal cancer, and pancreatic and ovarian cancer. So just something to monitor for, especially if you're providing primary care for these patients, is to stay on top of this training and discuss their risks with them.
Mm-hmm.
And then Dr. Cook, in clinic, when the heart failure attendings are seeing these patients, is this something that they're managing as well?
Well, we want to make sure that all of our post-transplant patients are hooked up with a good primary care physician, and because they need their regular screenings. Sometimes if there's problems with, if they present with something unusual, the malignancy will usually go into our differential. Probably the most practical one of this list are the skin cancers. And we make sure that we educate our transplant patients about good SPF protection and hats and that type of thing. Of course, when I was practicing in Arizona, it's really something. But the skin cancer really is about 100% when these patients will get a skin cancer in their lifetime. The longer they live, the more likely they are to get a skin cancer.
Okay. So it's time out from the longer they live. It's not, they're just increasing the chance. It's not immediately that they can get it.
No, they can get it immedially. Honestly, they really can. It's just because the immunosuppression takes away the body's ability to checkpoint, in the cell synthesis to make sure, and to destroy the cells that are abnormal. And so the body's no longer doing that. So the abnormal cells go and grow unchecked. And so that's the reason why they are at a higher risk of malignancy. And the other thing I'll tell you is that the risk of malignancy has to do with how much we immunosuppress them. So very early in this conversation, we talked about induction. And you might wonder, well, why don't you give induction to every single patient? Because if it protects their kidneys, then why not? Well, the reason why not is that the patients that get induction have a much greater chance of getting a blood cancer in the future. So like a leukemia or something like that. And so we want to make sure that that we are as conservative as we can be with the immunosuppression. So we want to hit the sweet spot of preventing rejection, but also preventing malignancy and infections.
That's actually really good. And I understand. That's really great. Thank you so much.
Mm-hmm.
And then post-transplant evaluation. So you monitor, like Dr. Cook had mentioned, for signs and symptoms of rejection. Sometimes anything will, warrant an admission and inquiry. Previous graft dysfunction, of course, those patients you monitor more closely, and then endomyocardial biopsy if needed, and then AlloMap, which we will include in the updated PowerPoint as well. And then just briefly concluding the PowerPoint, the epic tricks, and these are things that I learned in my PG 3 years. I wish I had learned that in my PG 2 years. So basically, when you go on the summary page of the main page of the patient on Epic, and you search for the different tabs that we have, like fever, vitals, things like that, if you search immunosuppression monitoring there, you'll have a whole tab that will open up with not just their dosages of their immunosuppression and what their last level has been and their labs that are pertinent. But you'll also, if you scroll down all the way to the bottom, you'll see a tab with their transplant history, which year they got it, what the recipient's CMV and EPV status was, and as well as the donors as well. So those are really, really helpful guides for us to just orient ourselves when you're admitting a new patient with a history of heart transplant to see what kind of background history you're dealing with. The DSAs and the AlloMaps is found on the media page on Epic, but usually the labs call the heart failure attendings who are on the service taking care of the patients as well. And then the path results from biopsies are usually in the lab results. And usually I just put an alert tab to alert myself when the results have actually come out or have been finalized. And I think that's all we got.
Yeah, that's extremely helpful. Thank you for putting together the tips and tricks. I think that will go a long way.
Well, thank you so much. Thank you for your explanations and helping us understand the complex topic that is heart transplant and immunosuppression.
Absolutely. Hopefully this is a good conversation starter, and I hope that you guys will all enjoy your CVICU-B rotation and you'll get a chance to be exposed to heart transplant. I tell you that one of the favorite things about my job is doing outpatient heart transplant, because hearing from people that come back and tell stories of the vacations they've been on and the family weddings they've been to, when we know that these people would be dead without their heart transplants, is so rewarding. So it's a big undertaking, but really worthwhile.
Absolutely.
So thank you, everybody.